Thank you very much, James, for that very generous introduction. When I was first asked to undertake this task, I couldn't resist it for a variety of reasons, but not because I thought I could necessarily impart any wisdom on the UK, but I thought I might learn a lot for myself. I will say I wish to thank the BJS Society for giving me this fellowship, but also I'd like to thank all the people who responded and participated in the questionnaires that I sent out and the hospitality that I was shown at the centres that I visited. The hospitality and generosity with time was fantastic and really greatly appreciated, so thank you all. And to all the people with whom I spoke about the state of the nation, the frankness and honesty in their responses was greatly appreciated. I've just got there a mini CV, mainly to demonstrate or to put up front my biases. I am an HPV and former transplant surgeon. I haven't been a transplant surgeon for about 4 years. I've been head of the Division of Surgery for 14 years. I still participate in general surgery on call. I was a registrar at the Royal United Hospital in Bath in 1985, which was a truly different era. I was a fellow in Birmingham on the liver transplant unit in 1991, and at Flinders Medical Centre in Adelaide we have for 25 years had trainees from the St George's rotation in southeast England. And as James has alluded to, my major focus with respect to management of the division, and this is really how I do manage the division, is clinical practice improvement and clinical standardisation. I'd also just like to make a brief statement about HPV surgery in Australia. The focus of HPV units in Australia is very much benign and malignant. There is no official designation. We do not have health jurisdictions telling us how to organise and arrange, with the possible exception of New South Wales. We do have an ANZ HPBA training program which has been in existence now for about 4 years. The units are inspected and minimum standards apply to become a training unit. I won't go into those in detail, but it is a reasonably robust process. There is a 2-year program with an exit exam. At the end, the exit exam is a written exam, and we have actually had to fail people. The basic mission of the program is to provide expert biliary surgeons, which is sort of a fundamental difference to Europe and the United Kingdom. The add-on of the cancer surgery and the liver transplantation is not necessarily for everyone, although all the trainees will participate in that. So the methods that I undertook to do this task was I tried to identify all the HPV centres in the United Kingdom, and I sent questionnaires to 30 and had responses from 22, a 73% success rate, which was very good. I visited 11 of those centres during the last few weeks. I also sent questionnaires to non-HPV centres, although the response to that was less robust, but I did manage to visit 7 of these centres. I've also managed to, so a lot of that information is qualitative. I have managed to obtain some quantitative information from the Scottish Cancer Audit, and I thank Steve Wigmore for providing that to me. From various reports and submissions, and Graham Poston has provided a lot of that, and SWORD data, and I thank Ian Beckingham for the information that he has given me. So this is what the questionnaires look like. This was just about what you did and numbers, and that was before and after designation. So, and I also asked a series of questions, and I'll go through a summary of the responses to these questions in a moment. And the final question I thought was the most interesting for me: are there any improvements in your service that you would like to accomplish within the next 12 or so months? These are the centres that I visited, the designated centres there on the left. Sorry, I've just spotted the spelling error. And the other centres on the right. So firstly, the results from the designated centres. Numbers were generally high. And look, I'd have to say that the improvement in cancer care in the United Kingdom has been phenomenal, absolutely phenomenal. So no doubt about that. Some units, there has been very little change. They were large units before, they are large units afterwards. Whereas other units have had a dramatic increase in the cancer resections. New skills, the most obvious is the development of EUS, both therapeutic and diagnostic. Most units have required significant increases in FTE. The improvement in intensive care in the United Kingdom has been most profound. When I worked here in '91 in the liver unit, I often felt that we could improve the outcome in absolute terms by about 10% just by inserting an Australian intensive care unit. I don't believe that difference any longer exists. Laparoscopic robotic skills, including duct exploration, minimally invasive necrosectomy, ablation techniques, and, at least in one case, islet cell autotransplant with chronic pancreatitis. With respect to targets, mostly the units report no significant problem, that they are able to meet the targets, occasional cancellations because of no ITU bed, some delays because of fitness assessment, and occasional delayed referral, although this was not identified as a significant problem. However, on the benign side, the situation is a little different, and not one unit that I managed to visit had the capacity to deal with acute biliary presentations, which I must say I found a bit of a surprise. The cancer is definitely a priority, and there's little or no theatre that's planned for acute benign. Some units identified that they were getting more and more referrals for complex gallbladders, and they were finding it difficult to accommodate this. Benign chronic disease, not well served. Remote management of severe acute pancreatitis, but many cancellations. I asked the question about MDTs for benign patients, and most units managed to do this in one form or another, sometimes in the form of a separate X-ray meeting, sometimes putting patients on the end of the cancer MDT. These were the sorts of improvements that the designated centres wished. Everyone wanted more staff of all sorts of designation. To increase acute gallbladder surgery rates, increasing intensive care access, outreach clinics and audit, create specific benign clinics, better collaboration with outlying hospitals, develop ITU independent post-op pathways, network MDTs and electronic referrals to a database, and daily consultant handover was mentioned. When I moved to the non-HPB centres, generally it was felt that the provision of acute surgical care was not a problem, that there were enough people to do it, there were enough people to fill the rosters. There was no significant difficulty recruiting surgeons to these institutions, and many surgeons seemed to nominate colorectal as a specialty interest. And I've certainly noticed this with the 25 years of trainees from UK or from England coming to Flinders. Almost every one of them has told me they wish to do colorectal. I hadn't really been able to figure this out, but I think I can now, in that at least by doing colorectal surgery, they can practice their craft, that is the cancer surgery, in a lot of centres and still do all benign surgery that they wish, so it gives them much more opportunity. Mostly the people from referring centres felt that cancer patients were managed in a timely way, occasional delays in transferring patients needing an acute intervention, variable concern regarding the communication between sites. Another thing that became apparent was a lot of these centres do still have experienced upper GI surgeons who ease the burden of delivery of care in these sites for benign upper GI or HPV disease. But this situation may change as these surgeons retire. Now, looking specifically at cholecystectomy, significant variation, there is a lot of variation in the approach to the acute gallbladder. And a lot of that is according to the skill set of the on-call surgeon. So there's a little bit of a lottery operating for patients presenting with acute biliary disease, depending who's on call at the time. That's a lot of variation. Lack of demand capacity matching for the acute load, and that's in both the designated centres and the peripheral centres. Elective most certainly takes precedence. And it seems that the surgeons have actually lost control of the elective operating list, that the elective operating lists are populated by people other than the surgeons. And this is not something that I'm familiar with. Overall, very low rate of acute gallbladder surgery, nominated as 10 to 30%. The best was one hospital that was managing to do 65 to 70% acute, but there was a specific focus on this by the surgeons at that hospital. Variable ERCP capability. This is very qualitative, but there did seem to be a relatively high rate of MRCP used, much higher than we would be using in the acute setting, a very low rate of cholangiography and a low rate of laparoscopic duct clearance. Now, in one hospital that I visited, the surgeon commented to me, he said that one of our problems is that it's regarded by health administration of it's just a lap chole. But as we all know, it's just a lap chole can turn into a disaster, and certainly there is some evidence of a bit of damage occurring. With respect to acute pancreatitis, the vast majority of this is managed at local centres. There is some acute ERCP being done for severe acute with a cholangitis component, but mostly these are sent to the tertiary centres. There's really almost no interventional radiology in the non-designated centres. Severe acute is managed locally until intervention required. Communication between the centres is generally effective, but transfer delays do occur, sometimes because of no intensive care bed and sometimes waiting for access for interventional radiology. However, I've been unable to really find any robust information regarding outcomes, effectiveness or efficiency of the management of this group of patients. The non-designated centres did nominate some improvements, particularly around acute gallbladder service and ERCP, clinical nurse specialists for malignancy patients to assist in the coordination. So it seems that the designated centres have clinical nurse specialists to do this, but in the peripheral centres they don't exist, and as I understand it, or at least not very much, and that is a bit of an issue for coordination. And some centres did nominate, and maybe my bias assisted in this, but some clinical standardisation for common presentations. Now, let's look at, and this is my attempt at estimating what's happening with respect to cancer. Resection for pancreas cancer, specifically pancreaticoduodenectomy. I have estimated, and this is for head of pancreas cancer, distal bile duct and duodenum, approximately 700 procedures done in the UK annually for this. Resection rate approximately 10%. That's based partly on the Scottish audit, which demonstrates a 9.7% resection rate, and partly on the SWORD data provided by Ian Beckingham. The estimated resection rate in the planning was 15 to 20%, which does now seem a little ambitious. If the 5-year survival of this group of patients is around 20, maybe 25%, a very significant benefit occurs in 140 people in the United Kingdom. Now that's quite a sobering number. Overall survival in Scotland has not changed, not even 0.1 of a percentage point over the last 10 years. Now that's looking at the population of patients. Remember, there have been most certainly very significant improvements in operative mortality, but because very few patients, only a small proportion end up having the surgery, it's not surprising that the overall survival has not changed. There is perception of improvement of management of patients with inoperable disease, and I believe that this is highly likely, but there's not any evidence, not any data to support that. Liver resections for colorectal metastases. The original projections were that it would occur at the rate of about 40 per million, which would give an annual caseload of 2,600 patients. This is just for colorectal metastases. In South Australia, I have a register of every patient who has metastatic colorectal disease in the state, and for the last 4 years, our resection rate has been 38 per million. In a personal communication with Kees de Jong, he tells me that in Holland it's 44 per million. The current evidence in the UK suggests that it's less, although it is hard to find robust information. At estimation of 5% of all colorectal cancer patients having liver resection, that would be the number. The SWORD data suggests it's about that number. But let's say that it's about 2,000 people with a 50% 5-year survival. A very significant benefit is going to occur in 1,000 patients nationally. I do, of course, recognise that there are also many significant benefits with the management of the non-resectable patients, and some prolonged survivals are occurring, so I don't wish to underestimate that. But look at laparoscopic cholecystectomy. Approximately 65,000 patients per annum, an order of magnitude different. For every 0.1% frequency of major bile duct injury, that's an extra 65. And it's estimated that there are about 300 major bile duct injuries in the United Kingdom per year. That gives a rate of between 0.4 and 0.5%. And some of this information comes from Darius-Merz's Collie study and the SWORD data. There is a 9% rate of operative cholangiography. Frequent MRCP, bile duct stone clearance, rare. In talking to people, it was thought that they were doing acute gallbladders about 10 to 30% of the time. The data suggests it's more like 10%. Low lap chole rate within 2 weeks of acute pancreatitis, the data suggests that it's actually less than 20%. The situation in Australia is a little different. I think the planning has allowed us to get a much higher acute rate for acute cholecystitis. We certainly would not like this number. We try and do that on the index admission in non-severe patients. The operative cholangiography rate in Australia is well over 80%. In many institutions, it's approaching 100%. So really quite significant differences in practice. I'm not wishing to make comments about which is right or wrong at the moment, but certainly significant differences. If we look at acute pancreatitis, around 30,000 admissions per year. That is a lot of admissions. Mortality is 6% overall, most of those in the severe, of course, but there are deaths in the non-severe patients. It equates to approximately 1,800 deaths per year. 25% of that 30,000 are severe, and the mortality in this group is 20%. Thus, the majority of the deaths are in the severe group, but not all. Now, Ian Beckingham has supplied me with some slides, and I wish to acknowledge this. And this is a series of slides now about patterns of performance of cholecystectomy in the UK. So this is the number of surgeons by designated subspecialty, and the largest group by far is colorectal. Other one represents day case surgery or emergency surgeons. Other two are general surgeons with perhaps more than 2 subspecialty interests. And this is the number of Hpv surgeons and the number of esophagogastric surgeons performing laparoscopic cholecystectomy. When you look at it, numbers by year, or number of procedures per year by subspecialty, the largest group is in the day case or the emergency, and still significant numbers with colorectal, not really all that many by Hpv surgeons, significant numbers by esophagogastric. When you look at the median annual number performed per surgeon, it changes significantly. Hpv and esophagogastric very highly represented, but the median annual number performed by this group is really quite small, and also, interestingly, vascular surgeons performing cholecystectomy. So this is number of cholecystectomies per year for colorectal surgeons. Over 200 are doing less than 10 per year, so a significant proportion are doing somewhere between 10 and 30 per year. And when you look at it for Hpv surgeons, there's a few doing a relatively small number, but some doing quite significant numbers. So quite significant variations in practice there, and quite a few surgeons doing not very many. With respect to, just wish to start to summarise this a little bit, the Hpv Cancer Service has dramatic major improvements across the board, and for that you are to be congratulated. That is been quite remarkable. It does, however, have very significant resource implications. Cancer care coordinators, nursing, medical, in all the disciplines, and a major focus on many multidisciplinary clinics. There are many of them, both at the local level and at the designated centre level. And many, many patients are churned through these multidisciplinary clinics, up to 90 per meeting in some cases. Now, I find it difficult to imagine that 90 patients would be discussed in any meaningful way in a 2 or 3, even 3-hour session at an MDT. And one surgeon did make the comment to me that he believed that his MDT was verging on the unsafe. Cancer and the targets and the numbers game. Now, this is not only from this visit, but something I've observed over the last number of years. There is significant competition between units focusing on this, the number. It's all about the number. And I think my gut feeling is that has actually gone too far, because the type of characteristic that it's breeding is everyone's sort of focused on what everyone else is doing and wondering how they can get a bit more of their territory to increase their own numbers. And I think this focus on having to do a minimum number, whatever that is definitely on its own having some unintended consequences. And I would far prefer the focus to become one of quality rather than number. And that's just a thought I leave you with. With respect to individual surgeon reporting, which I understand is here for colorectal surgery and maybe a few other things, is, I suspect, well, for me, another unfortunate development. The operational focus is very definitely on the team. And within your surgical units, the teamwork between surgeons should be paramount. And not that I detect any necessarily competition between surgeons, but it's important that surgeons look after each other and look after each other's patients. And the surgeon is not the only prognostic factor, not by a long shot. Unit reporting makes far more sense to me, and the individuals become the responsibility of the units. Now, there are a number of ways to achieve targets, and the reason targets are put there is to try and change the system to become more efficient, better, and the belief is that actually spreads throughout the entire system. But this is a very detailed operational challenge. To a significant extent, that has been achieved. But there are other ways of meeting targets, distorting the current system to meet the target so that everything is directed at the things that are measured and the things that are not measured become invisible. I'll leave it up to you to decide whether some of that's occurred. There's also manipulating the data. And I'm just going to show you an example from my own health system. This is over a 2 or 3 year period. Overdues are elective patients who have breached their waiting time. We have 3 categories of waiting time, and the target in Australia is that there shall be no overdues on the 30th of June. And miraculously, in South Australia, there are no overdues on the 30th of June. But I put it to you that this has not translated into systematic operational improvement, and how you can have patients disappearing off and disappearing and reappearing back onto the list, and regarding this as improvement is beyond me. I have pointed this out to our Department of Health. They do not care, because the Commonwealth funding is dependent on that number. So, just to change tack a little bit, and this is part of my thing about improvement in healthcare and clinical standardisation, there is, in all systems, not any one system, really significant variation in practice. A person who's studied this in some detail is Wenberg in the United States. There are 2 major studies on appropriateness in healthcare, one published in the New England Journal of Medicine in 2003, and it's called The Quality of Care in the United States. And Bill Runtsman in Australia repeated the study and published it in the Australian environment with exactly the same results. And actually, just to state that with some clarity, the major problems or major inappropriate care were omissions, not commissions, things that should have been done that weren't. Unacceptable rates of care-related harm, but in particular, an inability to implement best evidence, an average of 17 years from the evidence being available to its routine clinical adoption. And acute cholecystitis is potentially a marker of that. All the randomised trials, both in the open era and the laparoscopic era, have demonstrated exactly the same thing, that they should be done acutely, both for the health of the patient and healthcare resource. Improving quality of care, we spend a lot of time on this, gaining professional knowledge. Now, I remember a few years ago going to a meeting in the United States, and there were two parallel sessions. One was about ALPS, and one was about quality of care in surgery. In the ALPS room, there were no seats, people were distributed all around the room. In the quality of care, there were about 10 people. So we get much more fascinated by bigger and better surgery or bigger and better operations, that sort of thing. The systems side tends to get a little bit ignored, and the systems side is where I think we can gain significant ground by paying attention to it. So this is just a summary of some of the unintended consequences as I see it, and this list is open for criticism, of course. The HPV unit service plan has been done for malignancy, and the existence planned for a population of serving at least 2 million. The attention to the benign disease is unplanned and secondary. Many units are trying to accommodate this, but actually have limited resources to do so because it hasn't been planned out in the same way. The absence for targets for benign diseases, other than the 18-week surgery, has skewed care. Further centralisation on the basis of cancer may actually make the problem worse without significant benefits on a population analysis. Rationalisation on the basis of quality, however, is of course appropriate and reasonable. Benign HPV disease is far more prevalent than resectable malignant, but there is a very significant resource tied up in this component. And I do believe, from what I've seen, that there are possible opportunities to streamline triage, improve local management and declutter central MDTs without compromising quality, actually, from the point of view of the patient experience, potentially even improving it. So these are the problems needing a solution. Development, and it needs to happen in a stepwise way. Development of clinical standards for benign HPV disease, management of the acute biliary presentation, use of intraoperative cholangiography and MRCP. Now, I'm not saying it has to become mandatory routine, but what I'm saying is there does need to be some discussion about it. In my travels, in talking to people and showing them some of the evidence, a lot of people doing laparoscopic cholecystectomy are completely unaware of the evidence surrounding cholangiography and bile duct injury. Development of laparoscopic duct exploration, demand capacity matching for benign work, where, by whom and when, establish roles and responsibility for training. It's currently just random and unstructured, and routine processes for procedures, the clinical standardisation, and I'll just show a few examples of what I mean by this. So, in traditional quality assurance or managing a system or trying to improve something, we tend to do this, focus on the tail, assuming that everything that's happening in here is actually happening appropriately and well. And what we manage to do, we chop off the tail. That may be an individual, it may be a group, it may be stopping practice, it may be a variety of things, but actually to the overall quality, we don't shift the line all that far. Whereas if we focus on the whole system, we can make significant grounds, and I would say that has happened with the cancer work. I'm sure many of you in the room will recognise this. This is a B-17, otherwise known as the Flying Fortress, the largest production bomber ever in aviation history. In 1931, there was a fly-off in the United States. The prototypes with all the companies, Boeing, de Havilland, Lockheed, assembled at an airfield in the United States for a fly-off to see who would win the contract for America's next bomber. The prototype of the Flying Fortress took off, and that's what happened. The pilot, who was the most experienced test pilot in the US Air Force, was killed, as was his co-pilot. The plane took off, went elevated only for a small height, and then plummeted into the airfield just beyond the runway. In analysing what happened, with the Flying Fortress, the pilot had to attend to 4 engines, each with its own fuel oil mix. The first one to have retractable landing gear, had wing flaps, electric trim tabs for stability, constant speed propellers you had to pitch adjust with hydraulics. In other words, you get the picture. This was a very complex plane to fly. What the pilot forgot to do was to release a new locking mechanism on the elevator and rudder controls. He'd forgotten that step, and the plane crashed into the ground. So what they did was they developed a checklist. This was the first example that I know about where a checklist was actually developed. It has become, as you all know, extraordinarily common in aviation. And then the Flying Fortress flew 1.8 million miles without a single accident. And that was documented by Atul Gawande in the New Yorker in an article called The Checklist, and then he subsequently wrote the book called The Checklist Manifesto. Peter Provenost was an intensive care physician at Johns Hopkins in the United States. He noticed a very significant infection rate associated with CVC line insertion of 11%. Now that's quite devastating. Staphylococcal septicemias, heart valve issues and death. And so he developed an insertion and protocol which involved steps from beginning to end, full prep, draping of the patient, full gowning and gloving of the proceduralist. And the nursing staff observed the doctors and stopped the process if there was a protocol violation, and then it all had to be restarted. And over the next 15 months, there were 2 infections only, and he tested checklists in the ICU with other things, the ventilated patient, GI hemorrhage prophylaxis, with the same outcome. So, just to show one example from my institution, the plastic surgeons in an audit identified that there was a problem with breast reconstruction using prosthesis. This is breast reconstruction after mastectomy for cancer. So what they did was they defined the ideal process from beginning to end, from skin prep to timing and type of antibiotic, glove change, method of handling, etc. And this was agreed and implemented by all plastic surgeons on the unit doing breast reconstruction. And this was the outcome. The complication rate went from 33% to 17%, and the infection rate from 7% essentially to 0. There was 1 in the post-op period 6 months after the procedure, after a dental procedure that wasn't covered. So who knows? But really quite dramatic improvement by standardising and people following the standard. So in 2013, Saxon Connor and a few other people from Australia and New Zealand published this paper in Hpv, Safe Cholecystectomy, where they identified, I'm not going to go through all these, they identified a series of steps. And from this, so I'll just go to there, developed a standard method for laparoscopic cholecystectomy that they could use a checklist. And so this is the start of it. And this is a rugby terminology: touch, pause, engage, confirm. So WHO, then radiology, then this, and then confirm with surgeon to demonstrate, fundus retracted, Hartmann's pouch lifted, etc. I won't go through all the steps. But this is a method of standardising a procedure that may improve the quality and effectiveness of the performance of it. Now, I will go back to a comment about operative cholangiography. As I've said, I don't want to engage in a whole debate about it, but this is some evidence from the Galleris study, I think it was called, published in 2012 from Sweden, population-based cohort study, prospective database of gallstone surgery, 51,000 cholecystectomies, a 1.5% incidence of duct injuries. Now, that's all injuries, that's not major resection injuries. And they did an intention to treat analysis. Now and this had been previously demonstrated by David Flum, who was here this week, that there is a significant mortality associated with bile duct injury. It's not just a quality of life issue, there is a mortality associated with it. But when they reanalysed this according to performance or absence of cholangiography, either doing cholangiography or attempting to do it, significantly decreased the risk of death by 62%, which is a not insignificant number. Now, there are a number of ways of looking at cholangiography, and a lot of us, including me, find it hard to actually understand exactly why it makes a difference. But there is an extraordinary amount of evidence demonstrating that it does make a difference. I've never seen a paper demonstrating harm. And I do think that it should be thought of a little bit more in human factors terms, that it's part of a discipline in actually performing a procedure that is applicable to a whole population of surgeons. In much the same way as in the airline industry, conforming to a standard with a checklist that all pilots in the world now do has brought about significant safety improvements in aviation. So, I'm just going to move forward here. This is just to finish. This statement was made about 94 years ago now. The correct carrying out of routine means the difference between success and failure of our organisation. This statement was made by Hudson Fysh, who was actually the founder of Qantas. Qantas have not yet, and I'm flying with them in 24 hours, have not yet lost a person in this many years of flying to an aviation accident. And that is an extremely good record. So I just wish to leave you with this: problems needing a solution, and that is my summary of the impressions that I have gained during this last 3 weeks. I'll just say it has been an enormous privilege and pleasure to be able to undertake this work, something I've enjoyed enormously, and certainly I have gained a lot out of it. So I'd just like to thank you all.